We're really excited to have 8 health plans from across the country joining us today for this discussion on the important work of the California Maternal Mental Health Collaborative and the recently launched 2020 Mom Project. NICM's work on maternal mental health began in 2009 when we convened a webinar with experts to discuss the role of health plans in identifying and treating maternal depression. Following this webinar, we released an issue brief in 2010 reviewing the prevalence of maternal depression, the health risk of untreated depression, and economic consequences. The brief also provided recommendations and tools for providers to identify and treat depression and shared opportunities for health plans to promote a comprehensive approach to early identification and treatment of maternal depression. We're so pleased that the brief has been a useful resource to others working in the field, and it was through the brief that we were connected to the California Maternal Mental Health Collaborative. And for the past year or so, we've had the pleasure of working with Joy Burkhard, founder and director of the collaborative, who's joining us today. I know I've engaged in conversations with several of you joining us today to help inform a panel discussion at the collaborative's January forum, and we're so grateful for your participation then and continued participation today. We're really excited to be a part of the next phase of the collaborative's work with the launch of the 2020 Mom Project, and we're looking forward to the presentations and discussions today on how we can work collaboratively to advance these important recommendations on maternal mental health. I'd now like to turn it over to Joy, who, as I mentioned, founded and directs the collaborative and now the 2020 Mom Project, and is a true advocate for moms and families.
Thank you so much, Catherine. I'm thrilled to be here and to have an opportunity to speak with 8 other health plans about the work that we're doing and invite all of you to get engaged in a meaningful way as well, even more than you already have done in your organization. So as Catherine said, my name is Joy Burkhard. I like to disclose up front that I'm actually not a clinician, but I'm an MBA, and of course have been grateful for the opportunity to get close to clinicians and really begin to understand the importance of diagnosing and treating and building up healthcare treatment options for moms and families during this delicate time. I also want to share, it's not on this first slide, but want to share that I have been able to inform much of the work that we're doing through the California Maternal Mental Health Collaborative, which is a nonprofit organization here in California, but also the National 2020 Mom Project campaign has been informed, as Catherine mentioned, in part by the issue brief that she has put together and shared with all of you, and also my work at Cigna Healthcare. I work full-time at Cigna Healthcare in our Regulatory Affairs Department, so I don't work directly on this project, but it's been a very important link in understanding the powerful ways that all of us can get involved to solve this difficult and complex problem. I wanted to talk to you just a little bit about the collaborative, the nonprofit organization I'm with, to help you get your bearings around who we are and why this work has become so important to us. So we were actually formed in 2011, not quite 2 years ago, at the suggestion of the legislature in California through what's called a resolution, an Assembly Concurrent Resolution, ACR 105. And it was sponsored by the Junior Leagues of California, and some of you may know about the Junior Leagues. They're women volunteer organization that works with underserved women and children in local communities throughout the United States and several other countries. The Junior League sponsored ACR 105, and what happened with that resolution is it declared the month of May every year as Perinatal or Maternal Mental Health Awareness Month, and also the legislature tucked in a clause that suggested that a volunteer task force be formed to advance this important issue because the state didn't have the money to form a task force within an existing state agency. So the collaborative was born. Our mission is really about raising awareness and bringing more treatments and diagnosing women in California and throughout the United States as well. There's a quote here from Lori Gregg, Dr. Lori Gregg, OBGYN who chairs ACOG, District 9, and many of you may know ACOG, the American College of Obstetrics and Gynecology. ACOG has been right by our side throughout the beginning of our work with the collaborative, and you'll see here that she just is trying to give us some good acknowledgement about the work that we're doing. Well, now I'm going to talk a little bit about some statistics or some did you know facts that many of you on the line probably already know. It's important that we start out with this framework. And the first is, did you know that women in their childbearing years account for the largest group of Americans with depression? Did you know that postpartum depression is the most common complication of childbirth? And despite the prevalence of maternal depression, it largely goes undiagnosed and untreated. The American Academy of Pediatrics has noted that maternal depression is the most underdiagnosed obstetric complication in America. So maternal mental health highlights. We want to just go through the basics. Most of you likely already know these things, but just spend a little bit of time going through what it is that we're talking about when we talk about maternal mental health. With the focus, really, we're going to be talking about maternal depression. But as many of you know, up to 80% of new mothers will experience what's called the baby blues, which resolves untreated within 2 weeks. So that's a good chunk of new moms that will experience weepiness and exhaustion. And again, it's not a disorder. It's just something that will resolve untreated within. But up to 20% of women, 10 to 20%, will experience something more serious called maternal depression, which can happen during pregnancy and the postpartum period. One of the bullet points that I need to add based off of some new research that some of you may have seen about a month or so ago by Catherine Wisner suggests that maternal anxiety is actually as prevalent or even more prevalent than maternal depression. So we'll be updating this slide at some point to account for that, so something to keep in mind. And then we often hear about psychosis or hear about unfortunate cases that involve psychosis in the news media when women have unfortunately harmed their babies or harmed themselves. It's extremely rare but very serious, and it affects less than 0.2% of women, and again, the most dangerous cases in terms of potential harm to infants and the mothers themselves. So what exactly is maternal depression? It's a mood disorder with symptoms similar to the blues that persists beyond 2 weeks. Symptoms, of course, can be mild to severe, and of course, we point out that it's treatable. I'm not going to go through all of the symptoms, but they're very similar to symptoms of standard depression. One of the things that you often hear about that is different in these cases than standard depression are obsessive or intrusive thoughts that can happen with the form of anxiety that's referred to as obsessive compulsive disorder or OCD. And this actually is something that there's a lot of stigma about and a lot of shame about, where women have these obsessive or reoccurrent thoughts about, and they're actually suffering from depression, not psychosis. Maternal depression or anxiety, where they have reoccurrent thoughts or worries about they themselves harming their baby. It's very, very rare that a woman with OCD or depression would actually harm her baby, but it's something that women really struggle with when they have these intrusive thoughts. That can be a symptom that varies here in this population. So why does this happen? So evidence suggests that women who experience maternal depression may be more vulnerable to changing hormone levels and stress response. Additionally, we know that there's genetic factors and psychosocial factors, so women who have a history in their family of maternal depression or maternal mental illness, or even mental illness in general, at a higher risk. And also psychosocial factors and life stressors play a role as well, just like it would in any other type of depression. Risk factors, we've already talked a little bit about family history, substance abuse, lack of social support, talking again about psychosocial factors. This is a significant factor that's been studied quite a bit, including spousal support or partner support, or absence of a community network. A little bit about marital relationships, or difficult marital relationships can be a factor. Unwanted pregnancy, and all of you probably have seen those same studies, again, reminders that up to 50% of pregnancies are unwanted, so that's a significant factor here for us to keep in mind. Fertility challenges and financial instability again. And then many of you may know that the African American population is much more at risk. They're 35% more likely to suffer from maternal depression. Adolescents also face a higher risk, so that 35% versus the 20% among the rest of us, 10 to 20%. And then onset, the DSM-4 and 5, you all may have heard that there's been a lot of discussion about onset for this particular population. And onset is discussed within the first 6 weeks. Maternal depression generally happens within the first 6 weeks postpartum, which is an interesting thing for us to keep in mind as we think about screening in the postpartum period and when OBGYNs typically see their patients in the postpartum period. But it can be diagnosed up to a year, so a mom may suffer for quite some time before she actually reaches out for help. And then I made a comment here about the DSM-5, recognizing onset within the first 6 months, and in fact I've heard that the final DSM-5 may have changed that to 4 months or 4 weeks, so that's something I'm going to be following up on. Regardless, it's important for people, again, to recognize that women may have early onset but not speak up until later, and so diagnosis really can happen anytime after that first year, within the first year, and some argue that it can happen, women may speak up and be suffering, long after that and finally ask for help. And you may also hear that weaning, if a mother is breastfeeding, which we know many more women are attempting and trying and successful at breastfeeding, can potentially be a trigger as well, and that could happen after a year or so. Increases, why do we want to talk about the risk of untreated depression? So it increases risk to both mothers and infants and families, as many of you know. I wanted to go through a few of these, and the first sets of bullets here are really about untreated depression in general and what we see in general depression. The same holds true here for our population. So there's an increased risk of substance abuse or self-medicating, risk of ER and psychiatric hospitalizations, of course. There's an interference with marriage stability. It's often difficult for partners to understand what's happening. They themselves are very stressed out during this time of transition. It can definitely play a role in the ability for marriage to be stable. It impacts the mother and the partner's ability to work. Presenteeism, absenteeism, also returning to work. So disability time may be longer for a mother who's out and suffering from maternal depression. As you likely know, it increases the risk for preterm and low birth weight babies, increases the risk of preeclampsia, which we know can be life-threatening for a mother, and all of these things, of course, can be very costly to us as insurers. Increases the risk of infant neglect and lack of healthy infant-mother bonding. Many of you, this may be apparent, but for me personally, I actually had not thought about the importance of infant-mother bonding and the long-term effects it can have on a child who doesn't have that engagement. Parents, particularly the mother, and we'll talk a little bit about that in a moment. Increased risk of infanticide, which is when a mother takes the life of her baby. Again, that's linked directly to psychosis. Impacts the well-being of other children in her family as well, we want to point out. There's also an increased risk of abortion or adoption, which of course can be heart-wrenching for a mother and family when the mother becomes well and realizes what has happened. It impacts her long-term well-being and sense of worthiness when a mom is suffering and feels like she is a failure as a mother during this most precious time. At the bottom of that slide that I included some information about the cost of depression. This statistic comes from the year 2000 and actually from Catherine's issue brief. And we also have included here the cost of preterm low birth weight babies here as well, so take a look at those metrics. So if you're like me, and probably many of you on the phone have already started to think about this in your professional roles, but really sort of caused me to stop and pause when I got very close to this issue and say, well, why is this such a problem, and why aren't moms being diagnosed? It's obviously something we should all be concerned about from a public health perspective, from stability of our children, etc. So why the majority of OBGYNs don't screen, and again, typically we think about the OBGYN playing a role here, since the OBGYN is managing, the primary care physician managing maternity and part of the postpartum period. And those of you that are familiar with Catherine's issue brief probably saw these survey results as well. And OBGYNs state that they don't screen because they don't feel qualified, and I put here the majority are not trained in medical school. And in fact, I was at a conference this weekend, and the OBGYNs in the room were asked if they were given much training in mental health in general. And there were 3 OBGYNs in the room. 2 said they didn't study mental health at all, and 1 said maybe there was a segment for like 3 hours of discussion in medical school. You can see why they don't feel qualified. Another, significant elephant in the room, if you will, is that they don't have time. They feel like they got already a very full plate and very little time to do what's required from a medical perspective, and adding screening, for example, to the plate is just a little bit more time that they just don't have. The other piece about don't have time is that they know that with a positive screen, or can anticipate with a positive screen, that there's a lot more support work that is involved in treating this patient, finding resources in the community, managing medications, and perhaps taking the time to research what's available, what medications are safe, effective during pregnancy and lactation. And that is a big, they say we just don't want to open Pandora's box and not know how to help these moms, and we just don't have time. They also state, again, I alluded to this, that they don't know how to help or where to refer. And typically OBGYNs think about psychiatrists in particular, since they're MDs as well. They don't necessarily think about behavioral health, therapy and support groups and other types of resources that may be available in their community. And as we all know, there's a significant shortage of psychiatrists, an even greater shortage of psychiatrists who have any type of specialization in this particular area and feel competent to treat women during pregnancy for fear of harming the baby, etc. The other factor that they state is that they don't receive additional payment for this type of treatment or screening, and as you all know, typically we bundle office visit payments to OBGYNs. We don't pay them per procedure, so that's something that they state. I will mention that we've learned, and Doug Nemecek, who's on the line with me, we've learned that Aetna, I'm not sure if Aetna's on the line. If so, during our Q&A and comment period, perhaps you can share a little bit if you feel comfortable. But we do know that Aetna actually piloted and rolled out an increased payment for depression screening among their entire population, not just this maternal mental health or pregnant and postpartum population, and provided additional payment for screening. In the end, really saw that there was very little movement in terms of outcome increasing screening, but rather they had some very satisfied primary care physicians that were already completing screening, getting additional payment. So it's a very important piece of research or outcome for all of us to keep in mind, is that the real barriers really may be the other bullet points here on that page. I also like to say that often people think about pediatrician engagement, particularly in the postpartum period, since moms are in the pediatrician's office and maybe weeping and certainly are potentially showing signs that pediatricians are in a very nice position to pick up on and potentially do something about. And often they have great relationships with mothers about these types of things. But pediatricians cite the same barriers, so they don't feel qualified, they don't know what to do, and of course they also say that the mother is not my patient, so I really don't have responsibility, even though I may understand the impacts to the infant. I don't have a medical record for her, etc. So scope of practice is a significant barrier there among the other barriers that we already spoke about. You know, the other challenge, of course, is that women may not speak up. They may not know what's happening to them, be ashamed, never have heard about maternal depression or figured it couldn't happen to me, and often just think it's probably not that, it's something else, and don't speak up. So again, confused as to what's happening. There's also the general stigma of mental health, and to have some sort of label is scary and not something that people necessarily want to be associated with. They don't want to appear ungrateful for their babies. This is significant. And for moms that are in sort of lower socioeconomic statuses who have the real fear of having their babies taken away from them if they seem unfit as mothers. And we hear about, tragically kind of hear about those cases even when a mom's getting treatment of a mom losing a baby. So a very real fear. And then they don't understand the risk to the child's health. And what we have found and what research suggests is that women are much more likely to act and get treatment if they understand that their baby or even other children's health may be at risk. The other thing I put here on the slide is that sometimes what happens, which is just so tragic, if women do speak up, they find that there isn't any help available, or there are OBGYNs for the reasons we've discussed before. For example, just may not know what to do and may not offer any help, and say things that may not be helpful, like, oh, you'll get through it, or this is normal, and it's just the baby blues, or something like that, which can leave a mom feeling defeated and even more confused. So you probably also are curious about the Affordable Care Act and how does this fit into the ACA. And you probably also understand that the primary impact around the ACA, besides the healthcare exchanges or marketplaces, is the preventive care copay changes. And so what's happened here is that postpartum depression is considered preventive care, so any type of screening or screening for postpartum depression or any type of depression must happen at no cost to the patient. Of course, we as any HMOs on the call probably were charging $0 copay already for maternity benefits, so there's really no net change there. For PPO-type plans, we may have been charging coinsurance, so that has changed on most or all of our plans, I presume. So no cost for screening, and so $0 copays for maternity is the way it ends up working out. However, there's no requirement to pay for screening separate from the standard office visit, like Aetna's doing. That's not a requirement. I also wanted to share that, and there's also no mandate to screen, so there's no requirement in the states or through the federal government that all OBGYNs or all insurance companies must implement a mandatory screening program. I also like to point out what the U.S. Preventative Services Task Force thoughts were about this, and of course you probably know about the task force and that it's a body of well-known sort of researchers and colleagues and physicians with experience in preventive care that take a lot of time to understand the research and what should happen with particular treatments. And they could not recommend mandating coverage for screening because there's no evidence that screening improves outcomes. So there's no evidence that women are actually getting the treatment they need when they're screened, and that's primarily research-based. However, we do point out that general depression screening is recommended, and of course this means that screening in general for depression should be happening, and so we like to point out that means postpartum depression, etc., should not be excluded. It should be screened for, even though there are some challenges with actually getting women the treatment that they need. We talked a little bit about the exchanges or the marketplaces which are being formed in many of our states now for individual consumers to buy insurance, and not all of our plans are potentially participating in those exchanges, but there has been some interest among advocates in potentially influencing the exchange marketplaces to address insurer behaviors around maternal mental health. So we'll see if that goes anywhere and what might that look like, but something to keep in mind. And then there's also the USMelanie blocker Stokes Act, which was a portion of the ACA, which suggests that the National Institute for Mental Health consider additional research and funding additional research, and that Health and Human Services provide additional grants when funding is available. So general considerations. So impact to overall health and wellness of women, infants, their children, and families. We know that greater awareness can in fact be preventive and aid in early intervention. So if women and families are informed about these maternal mental health conditions and risk factors, etc., preconception and during pregnancy, that they may actually do things a little bit differently if they understand and perhaps prevent some triggers. Because of the shortage of psychiatrists and looming shortage of mental health and primary care providers, this is an interesting, dilemma for us. We also strongly believe that screening shouldn't be left to chance or be a luxury. And some of you may know that there's some great community-based models that are being developed and studied around postpartum depression that take a lot of resources and a lot of collaboration. Perhaps in one city, most of these are limited to certain practices. And we believe that's great, but we also believe that every woman, regardless of where they live and regardless of whether they have access to those types of programs, should be screened and should have treatment available. And those of you that are in quality programs may know about Six Sigma quality, and Six Sigma suggests that removing variability or improving consistency in systems, healthcare systems, for example, can lead to fewer defects. And of course, anytime we miss a mom and can't offer her treatment, that would be considered a defect. There's substantial variability in our current system. The other things that we like to point out is that we know that most women deliver at a hospital. We like to call this the hospital as the hub of maternity. Know that millions more will be insured because of the ACA, and that perhaps hospitals and insurers have a unique opportunity to make a difference here. And now it leads me to the 2020 Mom Project, and as Catherine mentioned, it's a national project. We launched it in May of 2013 during Women's Health Week. And it invites insurers and hospitals to adopt certain recommendations, and it also invites the public to get involved in meaningful ways. The public has an opportunity to look on our website and find out who's adopted the recommendations, what their implementation date might be. And Cigna, as you know, we're going to be hearing from Doug and myself as a Cigna employee. We'll talk a little bit about what we've done. Cigna appears on the website now as an insurer adopter. All of you would, of course, be listed there as well. It invites individuals to say this matters to them, and we attempt to encourage more hospitals and insurers to take a look at the project and consider adopting the recommendations. And what I'd like to do is ask all of those of you that are at your PCs to switch for just a moment to our live website, and I'll tell you how to get there in just a moment. This is a slide that appears on our website, and you can see Judy Mikasic, who is my co-chair in OBGYN with the collaborative, notes that this is a long-standing, silent public health and family health crisis, and that we cannot afford to keep traveling the same path, and that's why the project was launched. And Catherine, if you don't mind, I'd like to just quickly take everyone to the website. Catherine, are you able to do this from shared meeting space so that people can follow along as you direct?
I'm not sure, but I think if people click on the link on the slide, it should take them
to
the website, I think.
Good. I'd like to just show you the website briefly, and then we're going to turn it over to Doug, and we'll talk a little bit about how we're adopting the recommendations at Cigna. So I'm going to assume no one's having trouble getting to the 2020 Mom Project website, and if you need to just do it directly from your web platform, feel free. It's 2020momproject.com. I just want to quickly show you that we have a drop-down menu here for insurance companies. We may be changing that, by the way, to insurers/payers because there's definitely interest among the project not treating women differently if they're enrolled in ASO type product, administrative services only type product versus an insured product, and we do have some ASO type only programs, insurers or health organizations that want to get involved in the 2020 Mom Project. So that will probably be updated to say insurers/payers. Go down, you can see that there's a tab for the recommendations, and we're going to walk through those quickly together. There's a resource tab. There's an adopt tab, so insurance companies or payers that want to move forward with adopting the recommendations can do so directly on our website without direct engagement with us. We can also schedule a separate call and talk more of this in detail, but the adoption process can happen right here on the website. And then the last tab is the adopters, and Cigna is listed there right now. Aetna, I know I believe some of you may be on the line. We're in conversations with one other payer. We're having some conversations. May not be the lone adopter for much longer. And I want to ask everyone to just quickly look at the recommendations tab, and we're going to go through these quickly, and then we'll also be moving into our conversation about Cigna and what we're doing with the recommendations as well. But if you can click on the recommendations tab, I'm going to just quickly walk through them so you know exactly what we're talking about of what insurance companies or payers would be asked to do. This first opportunity to measure the rate of screening for perinatal depression, what's wonderful and remarkable is that the National Committee of Quality Assurance, NCQA, who many of us know and come to love, I'm sure, ACOG, and the AMA, American Medical Association, had been working together for several years to release what they call maternity care measures, and some of you may be familiar with them on several things, but they do address in Measure 3 and Measure 10 the importance of screening for maternal depression and also having a mental health assessment in general during the pregnancy and postpartum period. There's a live link on this recommendation page to that publication. You'll have it at your fingertips, and you can take a look a bit more. What's interesting is that in that maternity care measure set, they don't suggest who should be implementing these measures. They just agree that they're important. And so what we're saying, and I should also share that we've had some conversations with NCQA, and because of the situation that we've discussed before where it's difficult for OBGYNs to screen because they're really not in a position right now to be able to refer. They don't know how to help moms. It's a political issue, I'll just say that, as you can imagine. So again, the agreement was that this is important and a measure should be developed and agreed upon. And I quite frankly believe there there was some excitement that an organization like ours is actually going to suggest how the measure get adopted. And what we're saying is treat this measure like a HEDIS measure, since most of us, particularly those that are dealing with the insured population or not, carve out organizations or behavioral health only organizations, we're already doing HEDIS work. And so what the 2020 MOM recommendation says is treat this like a HEDIS measure. See how often your OBGYNs are screening. Go through that exercise, and we'll talk a little bit about what we're doing at Cigna to get our arms around this. We're just about to launch our program. And then report the results to one of your quality committees like you already are doing for HEDIS. The recommendation doesn't require anything more be done around that, but just a point of information. And what we think likely happen is that all of us will want to do more because we'll see that the rates are relatively low. We do point out that, and you'll see in Catherine's issue brief, that 44% of OBGYNs said they screen, but that could be that they sort of look and eyeball a mom to see if she looks depressed, which we know is problematic because women are great about hiding things, perhaps, and that even fewer use a validated screening tool, so a survey, if you will, to see if their patients are depressed for the reasons that we've already discussed. Most don't go there. So we'll go into details when Cigna talks about how we're implementing. Opportunity number 2, or recommendation number 2, is one that's really garnering so much excitement in our communities. In the maternal mental health community, OBGYNs are expressing a lot of excitement, and it's something that really doesn't take us too much work to do, and that is to create a credentialing program to identify maternal mental health specialists. And some of you may already be including a checkbox for physician or for mental health providers to note that they can treat this population. We're taking it a step further to really say that there's certain things that make someone qualified or should be put in place to before they receive that designation, be identified as a maternal mental health specialist. And those 4 requirements are here. I'll talk a little bit about what Cigna's done again to implement this requirement, but I will quickly just go through this. So someone would attest. We're not saying that you have to look for certifications and certification programs and validate that they're meaningful. None of that is required. It's really just asking them to attest that they've done these 4 things or have these 4 things, that they've completed 8 or more hours of CEU-based or certificate-based training in maternal mental health. They have treated 5 or more patients for maternal mental health and or have 30 hours or more, so perhaps 3 patients, but a lot of hours, however it works out. They're affiliated, we want that to be sort of loose. They're affiliated with a professional mental health organization, such as maternal mental health organizations such as the Marseille Society or Postpartum Support International. It could even be a regional or local organization. It doesn't matter. These are just 2 examples. And the point there is that we want them to be networked with other people doing this work so they can discuss complicated cases with each other, etc. They also would be then inclined to get training. And then number 4 talks about ongoing training, that they'll receive additional continuing education of no less than 3 units per year or 6 every 2 years. And then the recommendation also goes on to talk about informing your providers of mental health providers of the availability of the credential. If you already were offering the credential but without the specific requirements, that of course would require some additional work to share the new credentialing program. It may mean that certain providers would fall out if they could not attest to meeting those requirements. And the most important piece really, or that would make this complete, and not doing this would not sort of get us to where we really want to be, and that is identifying those providers that receive this or attest to this training and knowledge is providing them with an MMH, maternal mental health, or mom mental health designation in your provider directory or online directories. Again, an opportunity that there's a lot of excitement about. And the last one is the work that many of us are probably already doing, may have done some work here in the past, but it's playing our role in improving awareness, both in our member, patient population, and also among providers. And the first is to provide written communication to members. Regardless of funding, we really want everyone, our ASO members, to be able to learn of this, and that is to talk about risk factors, triggers, treatments, those types of things. This would also be shared with doctors, so primary care providers, pediatricians included, OBGYNs, family practice, and others that you see fit. The same information would be shared, and then also information about recommended screening tools. So for those that don't mind screening and maybe know of a resource in their own community, just to kind of reinforce that these are the prevalent screening tools. And we'll talk about the screening tool that our community recommends, and it's the PHQ-9 and the GAD tool, the Generalized Anxiety Depression Screening Tool. And then there's no screening tool right now for psychosis, but we're working on developing one with some researchers. So those are the screening tools we recommend. If they're not already on our resources tool tab for insurers, we'll put them there. You may share other validated tools. It doesn't really matter, but just in case you're curious what we recommend. And then you can actually pull down recommendations via PDF right here, download PDF. You can also download the adopter agreement. That's what shows up on the Adopt tab on the website. And then there's a general background page here that can be downloaded about the 2020 Mom Project as well if you want to share it with others in your organization. We'll have a new a new set of recommendations up as well for just behavioral health plans later today that does not include the HEDIS-like measures, since behavioral health plans aren't in a position to do that. Great. So I know some of you probably have questions, and we're going to ask you to hold them for just a moment as we go through what Cigna is doing, and then we'll have some time for Q&A here in a moment. So I'd like to actually introduce my colleague, Dr. Doug Nemecek, who will talk to you a little bit about what Cigna's commitment and his interest in this work, and then we'll go through each of these recommendations in more detail to share what we're working on at Cigna.
Great, thanks, Joy. Hi, everybody. This is Doug Nemecek. I am the Chief Medical Officer for Behavioral Health with Cigna. I've had the pleasure to work with Joy over the years, and over the last couple, really work with her focusing on improving access and improving the quality of care being delivered to pregnant and postpartum women suffering from mental health issues. And so as Joy got involved with and developed and set up the Maternal Mental Health Collaborative in California, and as she started to roll out the 2020 Moms Project, we were very happy to engage with her and get on board with working towards implementation of the initial recommendations for health plans that she just laid out. So we can quickly, I think, Joy and I, walk through sort of what we've done to date as far as working towards trying to implement these recommendations at Cigna, some of the things that we're looking at as we move into the future, and how we look to use these to help improve the access and quality of care that our customers are receiving.
Great, yeah, thanks, Doug. So I'm going to walk us through what's happening at Cigna, and I think I shared earlier that I don't do work in my full-time role at Cigna around maternal mental health or mental health, but have sort of been serving as a volunteer project manager around implementation, really because I want, again, to be informed and know the difficulties, if you will, in implementing these things. So that's why I'm also going to talk about implementation at Cigna. So we already heard about what recommendation number 1 was, and again, it's about that HEDIS-like measure, to implement a HEDIS-like measure. And from the AMA, NCQA, and ACOG maternity care guideline measures. Number 3 is the measure that addresses prenatal screening, and then number 10 is the postpartum period screening. And we won't necessarily go into detail around exactly what that screening requires. We've got a little bit of room to, each of us would have a little bit of room to develop exactly what the screening would look like, but I'll tell you what we're doing. We're actually just kicking off our screening next month, and I say August, I should actually say July. We're finalizing some of our tools this week, a data collection tool just in an Excel spreadsheet, and the questions that those that will be doing the medical record review will be, the statements that they'll be looking at, what they'll be looking at specifically. But some of the things that we're looking to do is track both whether OBGYN may be eyeballing or even asking a general question about depression or mental illness. And so we'll really look for all of those types of terms, well-being, emotional health. Is there something in the record that looks like a question was asked, the OBGYN looked at the patient, is mental health noted, postpartum depression, something like that noted. We'll track that, but then of course we're really interested in whether or not a validated screening tool was used, and we'll be tracking that as well. These guidelines actually list the validated screening tools, which is nice. So the PHQ-9, the Edinburgh, which some of you may be using in your maternity programs now. That's the most commonly used tool. The PHQ-9 is the tool that researchers think is the best tool for screening. So any of those tools, there's a Beck inventory that costs money, so it's not used very often, but it's a nice inventory as well. Any of those tools could be, would allow for credit for that second type of question. We're also interested in collecting data just sort of informally perhaps for a baseline around treatment. Again, what we think and what we've heard from our HEDIS medical record reviewers just in general who are used to looking at this OB period is that there's not a lot of medical record documentation in general, and that they don't expect to find much. So we think probably not find that many are screening. We're hopeful that we'll see like 5% of our OBGYNs are actually screening. That's just my gut feel. So probably won't see much at all around treatment. And also, if we do see that treatment is provided but not screening, we'll probably give them credit for that informal screen because something would have been done in order to provide treatment. We're again launching actually next month. We should have some more preliminary feel for what we're seeing in August. If anyone's interested in connecting with me more directly about some of that, we'd love to partner with you if you're interested, and as we hope in you adopting the 2020 recommendations. We want to share what we're learning and make some recommendations around screening. That's number 1, recommendation number 1, and where we are. So recommendation number 2 is the credentialing program. And again, the recommendations actually listed here. And what we've done is that we've updated our credentialing application, which we use in a tested specialty form. It's probably similar to what you guys do, where there's a checklist for specialties that the provider can just check off the box if they want to treat those types of patients. We've updated that form. There's an asterisk now next to maternal mental health. We've added maternal mental health and have an asterisk and require that they attest to these 4 bullet points that we've already read. We also are sending a notice that we've already developed to all of our existing providers to let them know of the new subspecialty and that they're all invited to obtain the designation now if they meet those requirements. And also, of course, we'll be making it available to new providers through that application process. We're sharing in our communication notice that the 2020 Mom Project website, and you could actually put this on your own website if you prefer, but we've tallied on our website. If you've got the page up, you can look on the home page. There's a box that says training resources. If you click on it, it shows the availability of all of the existing training programs in maternal mental health, because the idea, again, is to encourage people to get trained and have available treatment options for all women, therapists that may be qualified. So the training programs are listed there, and one of the other offshoots of the 2020 Mom Project is that recognizing that there really aren't enough training programs currently, we're working with some experts in developing an online web-based training program so that people from all over the country can easily be trained. So that is available. Again, you're welcome to put all of this on your website however you would like to share, and we encourage you to share what the existing training programs are so that more people who have an interest can be trained. I actually feared that if we didn't put it in our article that we might get phone calls, and then it would just be much easier to proactively share the information. That's what we're doing around the credentialing requirement. Again, not too difficult to implement that change, and we think it's going to have quite a positive outcome. The last recommendation around awareness, it simply addresses written communication, and that can mean your web-based, your e-newsletters. I think there aren't very many of us that are still mailing written materials. If you are doing that, I say kudos to you because I think it's still very valuable. That's ideal. But also, if you're just sending out e-newsletters to providers and members, that's sufficient as well. But the idea is that it's written communication and that there's some sort of push of written communication. So even if you engage with women, families through your online portals and you add information maybe on a home page or something like that, that's okay. We have to have some sort of way of letting them know that it's there. So the written communications, again, the requirements are here. We're actually just starting to do some of this at Cigna. We have some information, sort of generic information, as probably most of you do, on our websites in general about maternal mental health. So we'll be taking a closer look at what's on our website, but also developing these push communications for both providers and members. The other part of this requirement, which I didn't mention when we were talking about them from our website, is that the notice to providers, that last bullet on this, should offer a resource to discuss specific cases, including specific treatment plans. So you can really do this many ways. I mean, there's, I think, a range of possible solutions here. I mean, Doug has shared some ideas with me, and we're still, again, brainstorming what this might look like at Cigna, but there is an organization that's called Mother Risk that addresses medication use, which, of course, is something that generally OBGYNs are comfortable with. Maybe family practice, of course, comfortable with prescribing drugs if they know what drugs are safe and perhaps most utilized by other professionals for treatment during pregnancy. And Mother Risk is actually out of Canada, but services doctors and moms can call as well, wherever they are throughout the world, and provides the latest information on risk to mother and baby for certain drugs. So that's one example of how an insurer might be able to meet this requirement. That would be sort of the least amount of effort. The most amount of effort, which could potentially be very valuable, is to also provide the name of a clinician on site within your organization that is well connected with behavioral and OB, et cetera, and can help coach a physician or physician's office on all of the available treatment options and therapy and and other recommended treatment options. So those things are listed on the resource tab here, mother risk. I just want folks to know that there's really a range of things that can happen here. One of the other things that Doug and I have talked about is this could be another point of engagement for your maternity programs and Cigna's maternity program to get mothers enrolled. One of the difficulties, of course, is that not all ASO customers purchase that buy-up for the maternity care program, and so what does that look like for us? We recognize that everyone should be screened and treated, but do we already have case managers in that program then that can assist even if the mom is enrolled in a plan that doesn't have the buy-up? So, those are some other things that you can think through. That might be, one of the points that deserves, the most discussion through implementation. But again, it can also be as simple as just sharing the mother risk resource. So it's providing some resource to providers. So that would be the basic, and there's much more you could do if you wanted to expand it.
Thanks, Joy. I just want to add before you kind of wrap up and move to questions. The way I envision these three recommendations and the direction we're going at Cigna today to implement for them is really around what the recommendation 3 there, which is around more active engagement and education processes. Many of us have passive processes at education today, but taking it one step further to be a little more active in that education and support for families, moms, and their providers in the community. And then working with providers to measure internally and then increase the frequency of screening that's taking place to help to eliminate some of the barriers to screening in the community, to improve identification of people early in a depressive episode, and then by recommendation number 2, making resources and referrals and those providers best trained and interested in maternal mental health issues to be available in our networks to provide ongoing care for these women and their families. So a lot of work, but all ties together nicely as we try to increase and improve the outcomes for these women and their families. So I'll stop there, Joy, and then let you wrap up.
Yep, thank you so much, Doug. You can see that Doug really has the right perspective, and the ultimate goal is to build up treatment so that the barriers can be broken down and that providers will be willing to screen. There's also an interest in exploring other screening programs, and we can talk some more offline if folks are interested in doing more screening themselves. I think some of you are. But also, what does that mean? It really mean sort of managing or ensuring that they're getting treatment? To the U.S. Preventive Services Task Force comment that screening doesn't necessarily mean help, and that, of course, is the ultimate goal. A couple other things that I wanted to talk about that aren't listed on this slide that I wanted to share, that there are researchers that are interested in doing work with insurers. I was with some of them this weekend. And so if you're interested in adopting the recommendations and would like your programs to be researched and perhaps published ultimately, for others to see what you're doing, I will tell you that there's some interest in potentially, working with plans. There's a lot of interest in the 2020 Mom Project in general among that population, so keep that in mind. And I'd be happy to talk with you. I know Cigna's exploring some of this as well. Also, there are some inpatient and outpatient behavioral health programs that have popped up around the country that would be great for you to share in your mailings with providers. We can provide a list of those as well that specifically treat maternal mental health. The other thing that we would encourage you to do, and it's not a recommendation in the 2020 Mom Project right now, is that we also at Cigna looked at how often our patients are getting treatment. So we looked at those that had a pregnancy, diagnosis, and we looked at the claim experience during pregnancy and 1 year postpartum to see how often they received any type of inpatient or outpatient treatment. We didn't look at drug therapy. That's like another layer that would be very interesting to look at. And of course, that's the ultimate goal. If we know that up to 10 to 20% of women will be suffering and anticipate, moderate to severe cases, of course, need treatment, mild preferably too, that number, the number should be close to 10 to 20, 15%. So that's another meaningful measure if you're looking at doing some more work here. Again, not something that the 2020 Mom project is recommending at this point, but something that you could do if you wanted to take it a step further and really have multiple measures to look at around this. So I wanted to share with you before we open it up to Q&A that there's a small registration fee. It's like $269 just to help us cover some of our costs of the 2020 Mom project. It includes doing some press release PR work for you if you don't have a PR department that would rather do it direct. And we want to give you some sort of incentive to follow up with us and look at adopting the recommendations soon. So we want to provide 50% discount off that fee. Again, very nominal already, but closer to just $100 if you're interested. So I wanted to make that offer. We also have a LinkedIn group that's specific to insurers. We also have one for hospitals. It's something that you can go to if you just look for maternal mental health. There, you'll find our group. It looks like our little talk bubble logo here, and it says insurers. You can request to be invited, and we'll approve you, and then you can start to have more dialogues with us in that setting, all of us, and it's, again, a closed group, so fairly private and safe to ask questions about these things and implementation and share ideas. We also, I didn't share, we will be issuing new recommendations every year, and those who adopt the recommendations can choose to move to the new recommendations or stay on the year that they're already on, like Cigna may stay on the May 2013 recommendations for 2 years until we're sort of comfortable, and then maybe update to the latest iterations. So just want people to know about that we're sort of starting small. We might expand them, and everyone will get credit for whatever work they're doing on the website. So know that, and we also would love to have 1 or 2 insurers officially sit on our recommendation review board. So just wanted to make that offer available as well. And we have it looks like we have about 15 minutes for Q&A, and we would love to hear, again, questions you have about the standards, what Cigna's doing. If you have other ideas, feel free to share those as well, and any other work that you're doing within your organizations that you want to share.
Hi, Joy. We actually were supposed to end around 2:30, so I know we got started late, so we're running a bit late. I noticed a few people had to drop off, but I think a few people are still on the line, so I think the operator can open it up for questions at this time. And thank you to everyone for bearing with us and staying on. It's a really interesting presentation by Joy and Doug, and it's really exciting to see the work that Cigna is doing, kind of bringing these things to life after so many discussions about these recommendations for so long. If there's no questions, then we'll conclude our call, and thank you again, everyone, for joining us.
Thank you, Catherine, and thank you, everyone.
Thank you very much. Very informative.